Hello everyone, I am Lina Sharafi and today we are going to talk about chronic obstructive pulmonary disease, which is known as COPD. So in this presentation, we will define chronic obstructive pulmonary disease, we will explain the pathophysiology of COPD and their causes, we will explain the mechanism of action of various classes and subclasses used to treat COPD, we will identify the indications of drugs used to treat COPD, we will demonstrate the side effects of drugs used to treat COPD, and lastly we will remembering pharmacokinetics and pharmacodynamics of drugs used to treat COPD. So first of all, what's chronic obstructive pulmonary disease or COPD? So COPD is a pulmonary disease characterized by a chronic obstruction of airflow from the lungs due to an inflammation in the lung. So at the beginning, COPD starts with only mild symptoms, but as the disease gets worse, symptoms usually become more severe and will include a productive cough, shortness of breath, wheezing, and chest tightness. So now we will going deep to talk about the pathophysiology of COPD. So technically, there's two different types of diseases that can cause airway obstruction or COPD. The first one is emphysema, which is the destruction of lung tissue. And the second one is chronic bronchitis, which is a chronic mucus production, which usually associated with emphysema. And those two things together usually the main reason for COPD. So the inflammation in the lungs that will occur will going to cause vasodilation, capillary permeability, and clotting. So the effect of vasodilation will going to cause a more blood flow going through the alveoli. In addition, that fluids will going to move out into the interstitial spaces because of the capillary permeability, and this fluid will going to interfere with our gas exchange. And remember that these fluids are inflammatory fluids, so it's going to be thick and full of inflammatory debris and dead cells and neutrophil and macrophages and so on. And eventually it will going to be thick like a bus, and that is what causes all of these secretions that COPD patients are coughing up, which is again due to the capillary permeability. Not in just the airways, but in the alveolus too. So as a result of having inflammation and having some of those inflammatory mediators going to the site of this inflammation, we will have what is called oxidative stress, which is a result of having free radicals such as oxygen molecules that have become unstable. And then the normal cells will going to be attacked by those free radicals, which is a normal process for a response to an inflammation and are means to kill bacteria. And because COPD is an abnormal inflammation that is out of control and is not supposed to be there, and since there is not any bacteria to kill, that free radicals will go to attack healthy tissue and healthy cells of lungs and alveolus, and then end up by having this severe oxidative stress, and eventually these walls of the alveoli will become destroyed because of the oxidative stress and inflammation, and forming those big kind of bulbous type alveoli, and then we will lose some of the large surface area and we will lose some of the gas exchange capability, and this is why COPD patients have a low oxygen level, because they don't have the surface area to be able to do the gas exchange. So when the alveoli are normal, as you see in this figure of the normal passage of airway and COPD airway. So now, what's the causes of COPD? The main cause of COPD is a long-term exposure to substances that irritate and damage the lungs, which is usually caused from cigarette smoke. Subsequently, quitting smoking is the most important step to treat COPD. In addition of air pollution, chemical fumes, dust, they all can cause irritation and damage to the lungs.
Assalamu alaikum, I'm Riyadh Isbaiti, and today I'm going to talk about the first class that treating COPD is the short-acting beta-2 agonist. We have two subclasses, non-selective one and the selective one. Okay, the non-selective one, as we know, the adrenaline. Adrenaline have a lot of mechanism of action, as considered non-selective drug, but the two main mechanism of action that we are interested in is the first one, act as a potent bronchodilator on beta-2 receptors, and the second one is act as an anti-histamine effect. Now we have a lot of routes of administration, like subcutaneously and by inhalation as a nebulizer. It have also a short duration, the shortest one from 60 to 90 minutes, and we use it for acute anaphylaxis اللي هو hypersensitivity reaction. The side effect, we have a lot of side effect, but this is the main one: tachycardia, arrhythmia, hypertension, and hyperglycemia. We, as it considered non-selective drug, so we have another side effect that affects the whole body. Okay, the contraindication, we have diabetic, cardiovascular system patients, and asthmatic patient with hypertension or heart failure. Okay, the selective one now. The selective one, we have salbutamol, as known as Ventolin, and albuterol. Okay, the pharmacokinetic of it have short duration, but not as short as the adrenaline. This one, it's at least act for 4 hours. And also we can administer by inhalation, oral or parenteral injections. The mechanism of action, the first one, the first mechanism, it binds and activates beta-2 receptor in the lung that activate the cyclic adenosine monophosphate. Then it will activate the cyclic adenosine monophosphate dependent protein kinase that will reduce the intracellular calcium, and therefore it will relax the smooth muscle and prevent the bronchoconstrictor mediator such as histamine, prostagland, and mast cells. Okay, moreover, it have a little stimulation on the alpha or beta 1 receptors. The uses, we use it in acute asthma symptoms while the person or the patient exercise and had bronchospasm attack. The second one is a chronic obstructive pulmonary disease. The side effect, we have tachycardia, hyperglycemia, hypokalemia, and if we give it by systemic administration, like the oral one or the injections, it can lead to tumors, skeletal muscle tumors. So we prefer to use it by and give it by inhalation route to reduce the systemic side effects. Now we will continue with Khadija with the long-acting beta-2 agonist.
Assalamu alaikum, I'm Khadija Jamil, and we talk about the second treatment of COPD, which is LABA or long-acting beta-2 agonist selective, are formoterol, salmeterol, and arformoterol. LABA has the similar to SABA mechanism of action, which is decrease the calcium intracellular and lead to the bronchodilation and relaxation of a smooth muscle. And LABA indication for chronic asthma in combination with long-term inhaled corticosteroid, and we can use LABA as a monotherapy to treatment of controlled COPD. And pharmacokinetic, slow onset of action, bronchodilation effect lasts 12 hours due to its high lipid solubility, and administered by inhalation. And the side effects similar to SABA side effects. Precautions: LABA shouldn't use for acute asthma and have a tolerance when use LABA in a chronic use of LABA alone, because the down regulation of beta 2 receptor in lungs lead to an increased risk of death. Now, xanthidine derivatives class: caffeine, aminophylline, and theophylline. Xanthidine derivatives have two mechanisms of action, which is antagonism of adenosine A receptor, lead to block bronchoconstrictor effect of adenosine, so cause bronchodilation, and have a stimulant effect on CNS by block the inhibitory effect of adenosine, and decrease mediator release from mast cell. Mechanism to inhibition of two enzymes, phosphodiesterase 3 and phosphodiesterase 4, lead to increased cyclic AMP and increased cyclic GMP. This mechanism causes bronchodilation and relaxation of most smooth muscle and GIT, and inhibition of phosphodiesterase 4 lead to inhibit the release of cytotoxin and chemokinase, and this effect act as anti-inflammatory activity with a low dose of theophylline drug, and when the inhibition of phosphodiesterase 3 will increase the cardiac output and increase the cardiac contractility and arrhythmia, and cause in cerebral vasoconstriction, but in peripheral vessel vasodilation. So we when see vasoconstriction of cerebral, we use xanthidine derivatives as in migraine cases, because migraine patient has a vasodilation of cerebral, and weak diuretics at cyclic GMP. Pharmacokinetic: rapid absorption from GIT when take oral solution or rapid release tablet, and suppository and intravenous route of aminophylline drug. An indication of xanthidine derivatives in respiratory system in case with long-term control and prevention of symptoms related to chronic bronchial asthma, chronic bronchitis, and emphysema, and use aminophylline with IV routes in case of acute severe asthma and neutral apnea. While in CNS, as I say, xanthidine derivatives cause a vasodilation in CNS, or vasoconstriction, use in migraine cases, and cause CNS depression and delay physical and mental fatigue. In this case, use caffeine to a CNS stimulation and activity, increase activity. A side effect of xanthidine derivatives in GIT: abdominal cramps, hyperactivity, diarrhea, nausea, and vomiting. In CNS, headache, insomnia, and anxiety. And in cardiovascular system, cause tachycardia, increase the heart rate, and arrhythmia. Drug-food interaction: induction metabolism with smoking, venation, rifampicin, and phenobarbital. So we increase the metabolism of a drug, lead to the decrease concentration of a drug in blood, so decrease the effect of these drugs. And while inhibition metabolism with erythromycin and simastadine. High fat meal increase theophylline concentration, so increase the risk of toxicity. What about the toxicity of theophylline? Theophylline easy to cause toxicity because has narrow therapeutic index, so requires monitoring and chronic use, and toxic level higher than 20 mcg per ml, and severe complication with the cardiac dysarrhythmia, seizure, and death can be observed with level over 18 and 100 mcg per ml. And how treatment of theophylline intoxication: use the charcoal, because the charcoal acts as adsorbent of theophylline and increase the clearance from the body. So now we move to anticholinergic class with Roaya Sharif.
Okay, good morning. I am Roaya Sharif. I want to talk about anticholinergics. It's divided into short-acting like ipratropium and long-acting like glycopyrrolate, tiotropium, and aclidinium. Anticholinergics, have many receptors like M1, affect on cortex and gastric and salivary gland. M2 affect on smooth muscles and cardiac tissue, and M3 affect on smooth muscles and gastric and salivary gland. Ipratropium, short duration, and tiotropium is anticholinergic drugs. It is quaternary amine that was produced synthetically and has pyridine and cyclopentane moiety in its structure. Pharmacokinetic, don't diffuse into the blood and don't enter central nervous system. This leads to minimal systemic side effects. Ipratropium, short duration, 3 to 5 hours, and tiotropium inhaler, long duration of action, 24 hours. Are administered by oral and inhalation and parenteral forms. Indications of ipratropium and tiotropium. Ipratropium, adjunctive therapy in acute asthma, and usually combination with short-acting beta agonist and treat COPD, for example, albuterol plus ipratropium. Tiotropium, long duration and on therapy in severe asthma cases. Tiotropium and aclidinium and glycopyrrolate are treated COPD or in combination with beta-2 agonist in severe cases. This decrease COPD exacerbation, decrease the worsening of COPD symptoms. For example, formoterol plus glycopyrrolate. Okay, anticholinergic side effects: xerostomia, dry mouth, bitter taste. Precaution: ipratropium should be used cautiously with anti-mascaring drugs and other anticholinergic because increased effect of anticholinergic. Last drug, atropine. It is not used for treatment of asthma because it is non-selective M3 blocker, leading to many side effects like dry mouth and urine retention. It can cross blood-brain barrier and causes central nervous system side effect like sedation. It causes excessive dryness of bronchial secretion, making it difficult to expel, and has short half relief. Okay, now we move to the cases. The first case, a 65-year-old man with a blood pressure of 120 and 80 complained to his physician about shortness of breath and especially during physical activity. He has inflammation and damage to distal airway and alveoli. What is the cause of his symptoms? Asthma or COPD or pneumonia or pulmonary fibrosis. COPD because this all symptoms for COPD.
The second case is a 30-year-old woman with COPD went to the gym as usual, but in the middle of her workout, she had a bronchospasm attack. If you were there, what is your drug of choice? The first one is caffeine, second one atropine, the third one is budesonide, and the fourth one is albuterol. Okay, the albuterol because all the other choices is used for chronic or long duration symptoms, but the last one is used for acute and specifically for the bronchospasm attacks in the middle of in the workout or exercise, any physical exercise.
54-year-old woman with COPD, she ate food rich in fat and was poisoned and developed cardiac dysarrhythmia and seizure. What COPD medication caused this poisoning or toxicity? Theophylline, arformoterol, glycopyrrolate, or albuterol? Theophylline because this drug has a narrow therapeutic index, so easy to a toxic level.
A 16-year-old boy is brought to the hospital with shortness of breath and difficulty breathing. It is started about an hour after he woke up this morning. Oxygen saturation is 88%. The physical exam reveals emphysema and views expiratory wheezing. What is the most appropriate drug should be used? Monointazone, butran and glycopyrrolate, or ketotifen. It's glycopyrrolate because another choice treat asthma and painkiller and another drug not trait of COPD. A 16-year-old boy is treated with glycopyrrolate for COPD. What of the following is common side effect of this drug? Xerostomia, bradycardia, increased secretion, nasal dryness. Xerostomia, dry mouth, is side effect of glycopyrrolate.